Hi, everyone. For those who don't know me, my name is Meg. I'm a third-year MD-PhD student, and I'm a part of the QUIPS Queer Initiative for Physician Scientists Board. We are so excited to be hosting our second annual Gender and Belonging series. Starting with this, and this year we're specifically hosting Elle. Lett. We're incredibly excited to start with this lecture. And I want to begin by introducing Dr. Elle. Lett. Dr. Elle Lett is a Black transgender statistician, epidemiologist, and physician in training. Through her work, she studies how to measure and mitigate the impacts of discrimination on people's health, specifically focusing on population health for trans people of color, police violence as a manifestation of structural racism, and algorithmic bias. She serves as a clinical assistant professor of health systems and population health at the University of Washington School of Public Health, the scholar in residence at the school's Center for Anti-Racism, and associate editor for the Health Equity Journal. After completing medical school this year, she will start residency in emergency medicine. Please give it up for Elle. Lett.
Thank you all for having me. I'm really excited to be here to talk about the relevance of intersectionality to medicine and medical training in the anti-DEI era. I wanted to thread the needle of talking about, sort of doing some intersectionality 101, but I also wanted to talk about the science of it and how it applies to science and really get into the rigor. And also, we can't really talk about these things without putting it in the context of where we are right now. And so we're going to do that all together. So this is what it's going to look like. I'm going to spin around and move around a lot. That's just how I am. I'm going to start with who am I, give you a little background. Then we're going to define DEI, and then talk about how we got to this anti-DEI era. We're going to do what is intersectionality, and then why is it relevant to medicine, looking outward. And I'll explain what I mean by that when we get there. And then why is it relevant to medical training, looking inward. And then where do we go from here? And that's what we're going to conclude. So I'm going to tell you who I am because it informs the work that I do, and it'll help you understand the research, what I bring to it, and how I frame it. As a social scientist, these concepts, positionality and reflexivity, when done right, are at the core. But I think in the biomedical sciences, we don't really think about these two things. I want to challenge you to really think about who you are, what your background is, what your understanding of the world is, how that impacts your science, how you think about what's the important question, how you interpret your results. And I want you to even think about it in the context of a mouse house or basic science, because I promise you that who you are shows up there too. So positionality is our understanding of ourselves, of who we are and what we bring to the work. It's really your position in society relative to social power and dynamics. And reflexivity for research is a second order process. You look at that position and you see, what does it mean about how I interact with science and the work that I do? And so I'm going to critique presenting identities like this in a second, but this is who I am, and if you had to list it out. I'm Black. I say I'm blackity black. Black is a reference from a song, but I'm also, that's really core to my identity. And I'm a trans woman. Some of our identities are historical. I grew up in poverty, and I had experience with housing insecurity. I'm a physician in training like everyone here. I'm an intersectionality theorist. I am an epidemiologist. I'm a statistician. I'm all of these things, and all of that comes to bear in my work. And that positionality actually informs the things that I do. In my introduction, there was a wonderful introduction of some of my work, but I basically study populations that I am in community with and that I care about. I do trans health. As a trans person, that's important to me. As a trans woman, I'm in community with other people who are birth capable, so reproductive justice is important to me. As a Black person, I study police brutality because I'm directly impacted by it. And as a statistician, I am keenly aware of how artificial intelligence and machine learning is the new frontier where discrimination will be incorporated in medicine. And so as a researcher, I've taken up the task of addressing that. And honestly, and I think this will speak to many of you here, you can't avoid doing DEI work if you're Black in medicine because you just get recruited. People are like, oh, will you do this study? Will you do this thing? Like, it's just how it happens. And so this is a circumstance that I have decided to embrace with rigor. And when it comes to reflexivity, how I show up, I think a big part of reflexivity is thinking about your biases and having a way to be aware of them as you conduct science. And for me, intersectionality as a theoretical lens helps me do that. And we'll talk about why. But fundamentally, in normative societies like ours, by normative society, I mean that we have what's normal and we have what's not. And so by having what's normal, we have what we preference. We have what we construct our society around, which then makes people the things that are not constructed around. And that's how ableism becomes incorporated into our society. Everyone here was reared in a society with ableism, and so it's part of our thinking. And so we have to interrogate how that shows up in our work. Intersectionality helps me think about that and hopefully upend it as much as possible. So we've talked about who I am, and now before we get to how we got to the anti-DEI era, let's talk about what DEI is. But we need to define it. Stepping back from the words, at its core, DEI is a system of values and principles that help structure an organization, discipline, or a specialty to be its best and most productive self. And fostering those values is a science with its best practices, methods, studies, and implementations, and metrics. Now we can define the words, and these are the definitions I use. I like this figure because it shows you what things look like in the absence of one of them. But diversity, have you ever heard someone say a diverse individual? That is nonsensical. Diversity is a characteristic of a group. We can be diverse because we have an accumulation of different experiences, identities, and backgrounds. No individual is diverse. It's your group characteristics. Equity is how power is distributed in your organization or discipline along that diversity. If everyone who looks varied, or if all the variation is clustered at the bottom of your power dynamics, if all your Black and brown, Latinx, and disabled people are entry level, and everyone at the top doesn't look like that, then you're not an equitable discipline or organization. And then inclusion is the experience, safety, and joy of the people there. So you can be equitable without being included if it's always a fight. And belong is the state that maximizes all of those things. I like this figure because it shows you what happens in the absence of one. So you can have inclusion and equity without diversity, and just as the oversaturation of similarity, everyone looks the same, so it's easier to have harmony when there's very little difference. And so the point of this figure isn't to to know everything in this table, but it's to hammer home the aspect of DEI as the science. Sorry, I might have just, my bad. I'm bouncy, ADHD. This is a paper I did with a mentor of mine, Dr. J.I. Sola, and we list out strategies for operationalized inclusion and metrics. The takeaway here is that there are studied and tested strategies with metrics that have been already implemented. And so DEI is often treated as if it's about feelings and soft things, and that's true. I don't want to discredit people's feelings because that's what part of inclusion and belonging. But we assign science to feelings all the time. And that's what this is here. But part of that is what social science is. And as biomedical scientists, as physicians, we often are trained to discredit that, but that's actually part and parcel for the work we have to do. That's bedside manner. That's having an inclusive space. That's training with people who are different than you. Speaking of the science, this is a study that I did sort of critiquing representation in DEI. Come on in if you're outside. You don't have to wait. That probably made it harder to come in, but hey, welcome. I'm happy to have you. Part of the science, this is a paper that I did critiquing how we were looking at diversity in medicine. And this is getting at that sort of the rigor underlying the science. So in the late teens and early 20s, fractional increases in the representation of people of color in the medical students population were touted as the improvement in diversity, because there have been, if you read the literature, there have been diversity initiatives in medicine since the early 2000s, and we were finally seeing the fruits of that labor. But at the same time, where we had a 0.1 or 0.2% in the increase in the Black or Hispanic population in medicine, the United States demographics changed. Hispanic population went from 8 to 16%, Black population increased by 1/3. And so what I argue is that really all of the changes that those small increases were actually attributable to the underlying population demography and not to any of the ultimately fruitless implementations of diversity strategies that have been put in. And I developed metrics to show that. And so here it was a very simple metric, but it's the representation quotient that measures representation of different groups relative to the population over time. And for URMs, it's been stagnant since 2000. And this has been true since 2000. And I also did another follow-up study looking at each specialty, and actually across most specialties in academia, when you stratify by race and gender, Black men, women, Hispanic men, and women, the data limits you to binary sex, which is a different discussion altogether, have all actually had declining representation over time. So we haven't been keeping up with the variation in our population. And so that should be a marker that we haven't actually started to make a physicianship that looks like the people we treat. And a marker of any good method is that if people believe it enough to do it themselves, and these are other scholars using my methods across other specialties and other journals, JAMA Ophthalmology, Health Equity. Admittedly, I'm journal editor there, so maybe there's bias. Journal of Neurosurgery, I ain't editor there. So yeah. And so that is me showing you the science of DEI. And I encourage you to equip yourself, which as all of you are scholars, albeit in different disciplines, you should be able to equip yourself with understanding it in that way too by reading some of this literature. So to beg the question, how do we get into this DEI era? And the first thing I want to say is that we really have always been here in a bipartisan capitalist society where the core of our governance is as much concerned with maintaining power and profits as the well-being of people. Attacks on movements and fields that seek to upend those norms are the status quo. But there's a twist this time, and that is that scientists are part of the problem in this one. And I wanna trace it back to George Floyd and the police brutality and the racial reckoning of 2020 now. I put the asterisk to George Floyd because it's a reminder to me to approach using him as sort of a before and after time point with the gravity it takes, it requires. We in public health and medicine often use George Floyd to represent the time where white people and other people who aren't directly impacted by racism start to realize it exists. And I think that we can't avoid that reality, but it's important to note that that was a tragedy. It wasn't his choice to be our marker for racism. And so a man's life was lost and he should actually be alive. That shouldn't be what his name means. And so I want to approach that with the appropriate gravity it deserves. Right on the heels of this and the police brutality and the movement to demand justice, racial inequities in COVID-19 pandemic put this racial reckoning firmly in our backyard as clinicians and medicine, people as healthcare and scholars of academic medicine. And so, rightly, I would say, academic researchers, funding agencies became responsive, and you saw grants for studying structural racism and really trying to do something. And it invited people to the table to really sort of get mixy and do the work of achieving health equity across racial inequities. But academia is as capitalist as the rest of the society. And I want to preface this by saying that good intentions and self-interest can coexist. And the reality is that even me, and I'm very junior in my career, I was doing health equity work well before George Floyd. There were people doing health equity work well before this sort of recent fervor. But with this sort of watershed of resources that were being allocated for it, a lot of scholars who had never done that work became interested. And you have what I termed, this is probably one of my most influential contributions to the literature, because a lot of health equity scholars, a lot of Black health equity scholars saw themselves in it, and I feel, and it's important to me that that happened. But this health equity tourism is the practice of investigators who have never engaged in this work, parachuting into the field to sort of take up the resources that were all of a sudden being allocated and kind of polluting and diluting the work and draining the capacity of health equity scholars to really do the way it was supposed to be done. And I think it's important to note that we should all be care about achieving health justice. But when your motivations are to get the grant and you are not paying attention to the science that has been done and applying the rigor that has already been there, I think it ends up being to our detriment. And that's actually what happened. With this rush of new investigators, DEI got sloppy. DEI became whatever anyone wanted to define it as. And as it became more and more amorphous, people who became anti-DEI didn't have to define it either. And so now we're in a place where DEI represents everything. It represents gender, it represents race, it represents everything that specific political parties or movements want to have diminished. And that's what I call the anti-DEI umbrella. These are all things that I study, and I would, as a scholar in these fields, I would have never called them that very specific organizational power and distribution study of DEI, that what it was meant to be. But this is what it's labeled as, and this is actually all words that are lifted from the executive order. That if I didn't use any of these words, none of the papers that I published could exist. And so, and none of the papers that I published have DEI in them at all. And so that is the place we're in now. And that's the context in which I'm going to introduce and talk to you all about intersectionality. When people introduce intersectionality, they usually start with this sort of map, a list of identities. I hate that. I think that it's well-intentioned, but it simplifies it to the point of it almost being meaningless. Because intersectionality is not about identities in isolation, it's about power. And I think we can demonstrate that best by Kimberly Crenshaw. She's a critical legal scholar who's credited with popularizing it for the academy. And this quote, I'm gonna read it because I don't wanna miss it. Intersectionality is a lens through which you can see where power comes and collides, where it interlocks and intersects. It's not simply that there's a race problem here, a gender problem here, and a class or LGBTQ problem there. Many times that framework erases what happens to people who are subject to all of these things. And so particularly where it comes to health and health inequality, intersectionality, those identities are most meaningful because our society stratifies access and power along them. And so it's the power that makes those identities relevant when it comes to health inequality. I could teach and have taught an entire course on intersectionality, so this is a very brief introduction to some core principles. But one of the things that I think is useful is that when you really think about it, many of you live this, and so some of it will be intuitive. One of the core principles is that identities are contextual and interacting. And so contextual, being a mother, for instance, in America is very different, particularly for Black women, than being a mother in Europe. And we see that borne out in the maternal mortality crisis that we see here, where Black women die at rates that are comparable to so-called, problematically called third world countries. And social identities being interactive, my transness is shaped by my Blackness and vice versa. My experience as a trans person is not going to be the same as someone who is white. Multi-level power structures, I think, unfortunately, this is very clearly seen today. You can look at power on interpersonal and structural levels, and structural can be national, state level, and the policy environment right now is one manifestation of it, where different states and even nationally, they are legislating away trans rights. And so that's an example of multi-level power structures in a climate where interpersonal trans violence is also ratcheting up. This one, this simultaneity of mutual constitution, this is probably the most social science nerd, I don't quite get it, of all of them, but I think it's important with that the power systems we're talking about, they're actually comprised of each other. Classism is made up of transphobia and other ableism. The way those things are experienced at the same time, I can't parse apart racism from transphobia in the way I navigate the world and how I experience them. And the last one really originates at the roots of intersectionality. It's been adapted to research in academia, but it starts in activism. And so to do that right, it's about the process and centering historically oppressed groups. And so if we wanted figures that get it right better, these would be two that I would use. I like this one because it lists those identities, but it immediately connects them to power structures. And I like this one because it talks about that sort of collision and how they come together to make something unique in the context of motherhood and HIV. So now you've gotten a crash course in what intersectionality is. Why is it relevant to medicine? And looking outward, I think as a scholar of DEI and health inequities, I try to split my work between things that look inward, studying other physician and healthcare providers, and things that look outward, studying populations that we're supposed to care for. And so this is a case study on trans health and HIV. There's going to be a fair amount of trans stuff because that's what I study. One of the easiest ways to see an intersectional health inequality is to simply cross-stratify disease outcomes by social identities. And so the overall prevalence of HIV in the country is probably fractional percentages, but stepping back, this is a meta-analysis from 2019. A meta-analysis is basically you take small studies and use statistical approaches to combine them to get a single estimate, and they're only as good as the composite studies. So this has to be taken with that caveat in mind. But the overall estimate for HIV amongst trans folks is 14%. But when you cross-stratify by gender within the trans community, trans women, trans men, and race, you see that the estimate, based on this meta-analysis, is 44% for Black trans women and 26% for Hispanic trans women. And so with the collision of trans misogyny for trans women and racism for Black and Hispanic trans women, there's this higher incidence of HIV. And if you stop there, if you just focus on the identity, you're at risk for pathologizing those people who live at that identity. And that's why I put the emphasis on power. And so I call that identity focus like intersectionality 101 or level 1 intersectionality. But I really want to push people to say, how do we study, how do we interrogate those power systems and the experiences of discrimination and link that to those health outcomes? And that's very challenging. This is a study that I did with some colleagues where we attempted to measure discrimination on two levels, interpersonally and structurally, across two identities, racism and transphobia. And we wanted to look at how experiences of that discrimination was related to behaviors that are associated with HIV transmission amongst youth. That's basically summarizes this slide if you don't feel like reading it. And so how do you measure structural racism? It's a lot of different ways. There's no definitive way of doing it. Each way has its own benefits and sort of challenges. But one common way is to aggregate policies, and another common way is to aggregate the effect of discrimination at a specific geographic level. And so that's what happens here with the State Racism Index, which is one that I used. And so basically you measure how segregated a state is, how big the poverty gap is, and how inequitable the distribution of wealth is, and economic opportunities, and how racially biased the criminal justice, experience with criminal justice are based on the incarceration rate gap. And these are all demonstrably related to racialized processes. And this gives you an aggregate measure of how racist the experiences are of people who live in that region, in this case at the state level. There's lots of caveats to this, but it was validated by it being a good predictor of various race-related outcomes in the study where it was invented. And I have a similar measure for structural transphobia. I won't go into detail about all of them because we'd be here all day. At the interpersonal level, this is it's a little bit more straightforward, but again, it also has caveats. You ask individuals their experiences between people. And so for measuring interpersonal transphobia, we use a survey and we simply ask people, trans people who were in the study, their experience of discrimination, which looked like being denied medical care because you were trans, or rejection, which looked like being kicked out of your religious community, or victimization, which could look like physical threat and violence, or non-affirmation, which could look like purposeful misgendering. Aggregate those experiences, and that gets at the interpersonal transphobia. And a similar one for race. And what we found for 3 behaviors that are associated with HIV transmission, these are the colors of the trans flag. Magenta is transphobia alone, pink is racism alone, and blue is both. And again, we already talked about simultaneity. Blue is really what's meaningful that relates to people's experience, because you can't really experience these separately if you're Black and trans, right? And at least for this behavior, alcohol or drug consumption prior to sex, and transactional sex, which is exchanging sex for resources, more experiences of discrimination are associated with engagement in those behaviors. There's some causality discussion that needs to go into there and more charting out the pathway. But this, to me, is bringing intersectionality more closely to bear on rigorous public health and medical work, because they try to more directly measure that power as opposed to those identities. But I can see how that example might feel a little removed from you all. So as people who are probably in the midst of clinical rotations, I want to give you one more that might feel perhaps more connected. And that's clinical algorithms. Clinical algorithms are really just decision-making tools that we use in the clinic. They can look like output from machine learning data. They can look like the GFR calculators that have been much discussed around race. They can look like the atherosclerotic cardiovascular disease calculator that we are all told to use on MedCalc when we want to get extra points on our internal medicine rotation. And in an ideal world, we get this clinical data, and then we as clinicians or clinicians in training work with our patients to integrate that data into a person-centered shared decision-making plan. That's not actually the world we live in. These clinical data and these algorithms are constructed against the backdrop of society where racism, sexism, all of these forms of discrimination are the backdrop, are the data-generating mechanism. And so those things necessarily get incorporated into the algorithm. And that comes from just the mechanics of most statistical regression tools, where you minimize the average error, which will necessarily preference the dominant or overrepresented groups. But it also comes to bear from how people experience the healthcare system. We all know that certain populations have different experiences in the healthcare system. For access reasons, they may have less frequent appointments. The quality of those appointments, if we're honest, aren't always the same. We know that from ED studies where emergency department studies where Black people, our pains are undertreated. This has been demonstrated. Higher misdiagnosis rates. And so when you're creating this differential quality or quantity of data by groups, that necessarily makes those algorithms perform differentially by groups. And so that's what happens here. So as you incorporate this biased data, that bias gets propagated into our decision-making and ultimately to this person's health. One form of bias is simply exclusion, tools that weren't designed with you in mind. This is to see if anyone's awake. Is there any problem with this tool? Is there anybody who you could think of who would be excluded by this tool? Go ahead.
Trans people.
Yeah, me.
Or non-binary.
Or at least it's questions like sex assigned at birth, hormone profile, how long, like, I don't know what to put in for these things. And I'm being glib, but it's also true. How do we implement this calculator for a trans person of color? Let's talk about the background of it. It's a race-based clinical algorithm, but if you look under the hood, race is Black or white. And so that actually means that it's not relevant to like a lot of y'all in here. I'm making assumptions, pardon me. It also, in sex, we can assume they mean sex assigned at birth, but that's an assumption. Sex is actually a multidimensional biological construct, at least when it pertains to medicine. I mean, you have differences of sex development. You have people's hormone profiles. So, and that's very cardiovascular relevant. Would we change sex based on how long someone's been on gender-affirming hormone therapy? All these things are unknowns, and because the algorithm wasn't designed with them in mind, we're just making our best guess. And so with some colleagues, there's a theme. I only use studies I did. We actually wanted to see how different interpretations of those variables would change the results. This is a grid. I'm going to walk you through it because it can be feel complicated, but assume everyone is So this is a grid that has gender identity, sex assigned at birth, and gender affirming hormone therapy for Black folks and white folks in the study group. And so, and it's the same variables across the X and Y. And so the grid, this diagonal, it's like you wouldn't change. The calculator puts the same thing in. But what would happen if everybody who was Black and you took their gender identity, so it would be female, and you changed it to the sex assigned at birth, so it would be male? The mean absolute percent difference for the risk calculator would be 57.7%. That's how wide the difference would be. And so the reclassification rate would be 12.9 if you were using a cutoff for a high risk for a cardiovascular event. So 12.9 people would be moved from a place where they wouldn't, 12.9% of people will be moved from a place where they would to wouldn't have an intervention. And these are all reasonable interpretations of that calculator, and there is no guidance for it. And so this is my first study might have felt divorced from some of you, but this is right up your alley. You will have a trans patient who come in who could have elevated cardiovascular risk, but you don't know how to elevate it. And so you're going to have to integrate your own clinical knowledge, your understanding of where these tools break down to make the best educated guess you can. And so I hope I've convinced you it's relevant outward to your patients. Now I want to talk about inward facing. This is a false dichotomy because I'm sure you know, or maybe people who navigate being patient and physician. So, well, I'm a diabetic. Y'all saw it on the first slide. So there was one time I went to the LGBTQ clinic, which is also where I get my care, and then I rotated there the next day. Everybody was confused. But what does it look like for trainees who experience intersecting forms of marginalization to become physicians? This is a study we did looking at the association of microaggression with depressive symptoms and institutional satisfaction among a national cohort of medical students. This is the microaggressions. You can read them yourself, but hopefully we are familiar with what microaggressions are. And this is another demonstration of that sort of level 1 intersectionality. The data was limited to binary sex. I didn't design the instrument, but this is what we used. And so in this orangish color, female, this bluish color, male, and race. And you can see that Black, Hispanic, and multiracial have higher mean microaggression scale scores. And this is calculated by people respond to how frequently they experience each of these microaggressions. And that is turned into a score per microaggression and added up. And within each group, female is highest. And so again, those two forms of oppression interacting to bear out in the data. And just to show you, before people get too alarmed, this is the maximum reported frequency. So this means that across all 16, individual's highest one. So that not every single microaggression a person will experience every single day. But 35% of people had experienced one microaggression at least every day, depending on which microaggression it was. And so that's a lot. And most commonly, they attributed this microaggression to their gender or race. Again, jury's out on if people can actually parse those. But I mean, if somebody says something about them explicitly, one would argue that's a macroaggression. But either way, at least people's experience or intuition is that these were the main dimensions in which they were experiencing that sort of marginalization on. And this isn't just, this has objective results when it comes to health outcomes. And so we wanted to see if those experiences of microaggression related to depression. So we used the PHQ-2 screen. And people who had higher experiences of microaggressions were more likely to screen positive for depression, which I don't think shocks anyone here, but that was also related to burnout. And these aren't isolated. Oh, sorry, I skipped ahead. That is the subjective experience of people kind of to some degree inferring how people view them. Let's look at it the other way. This is a study we did evaluating 4 years of data on how emergency medicine residents were scored by their evaluators, so how they were being graded as they went through their residency. And it's important to note we control for step 2 score going in. And so if you believe that step 2 score is a good measure of medical knowledge, then this is adjusted for that. So any difference here can't be explained by that. And what we see, and so this is that people are evaluated at the middle and the end of each year. These are 3-year programs and 4-year programs because that's the specific thing about EM. And this is the key. And what you can see across, this is the overall assessment scores, but it actually broke down within the specific dimension. You will all eventually, if you go to residency, understand these ACGME evaluations more, but they have patient knowledge or medical knowledge versus like professionalism, all these different dimensions. This is the aggregate one. You can see over time, there's a gap that starts to be present towards the middle and it widens and it's worse for URM females. And so what they're saying that they are being evaluated despite, at least after adjusting for any difference in medical knowledge. So for something on top of that, they're getting evaluated as lower performing. And so you can question that, be like, one response that would be like, maybe they are lower performing. But if you don't think there is an intrinsic difference in their ability, or that intrinsic difference would be measured by step 2, then the question is, where is that difference coming from? It's your subjective assessment of them, or, and this is even perhaps more sinister, it's how you're training them. And that's, people worry about that in surgery. There has been instances of Black trainees getting less surgical time and things like that. And so either way, if you take responsibility for helping someone become a physician, on the basis of their identity, there should not be this widening gap. And these are not isolated findings. Experiences of discrimination and poor outcomes. This study showed that people with multiple marginalized identities, I think they had 3, so like LGB, non-white, and something else, was associated with burnout and exhaustion. Here, they said it showed that physicians who were female and racial and ethnic minorities were more likely to experience discrimination from patients, families, and visitors, and that was associated with burnout. And this was a study where they showed that discrimination and mistreatment was common for surgical trainees, shocker, on the basis of race and gender, and all forms were highest among women, and this was associated with suicidal thoughts and burnout. And then these are also documentations of bias at the medical student level, emergency medicine residents, and internal medicine residents. So the takeaway here is that there's a rich literature that shows these problems and that they manifest intersectionally are pervasive in our training. And so that's why it's relevant here. And so what do we do now, even in the midst of the anti-DEI era? This is going back to me. I have over 70 peer-reviewed publications. I have invited talks and national conferences across multiple disciplines. I was the Cell Press Rising Black Scientist awardee, inducted into AOA, associate editor, and I'm a faculty member while finishing medical school. Humility is super important, especially when it comes to cultural humility with our patients. But by every metric, I'm exceptional. And thank you. And I have experienced racism and transphobia during my training. And the point isn't to have opportunity to brag, but it's to say that excellence does not protect you. You can't excellence your way out of it. It's not an individual issue. It's an institutional issue. Your institutions, our discipline, our profession has to change around us. We're not the problem. And this is where I put this disclaimer. Nobody who invited me saw any of my slides or had anything to do with what I said. Anticipatory compliance is how fascism takes hold. Resistance is a constitutional protected right. I'm responding to how quickly I've seen many of these elite institutions completely fold in response to the executive orders and federal regulations around DEI, which again is just a amorphous catch-all that really has, from the regulatory standpoint, become everything that's related to justice and health. And Penn scrubbed everything within a second from their websites. And these things have no teeth until they make it through the legal system, which is our right to respond to them. And then I juxtaposed it to how all of these institutions responded to the other executive order, where indirects were cut to 15%. You all are scientists, so hopefully you know what indirects are, but that's the chunk that institutions get on top of their grant. Each institution negotiates it separately. Penn and Cornell probably sit somewhere between 60 and 80%, where if you get $1 million grant, they get a 60 to 80% on top of that to do what they will. And Trump, and also like less prestigious institutions get smaller indirects. Trump cut that to 15% across the board. And I have never seen such a united and swifter response. 22 states and a coalition of universities have halted the implementation of this swifter than any of the executive orders on trans health and DEI or anything else when it affected their bottom line. My institution is on the list of those from the coalition, and so is yours. And so what I'm saying, I don't go to Cornell, so I don't know. What I can say is that now is the time to demonstrate the strength of your values. If you only care about it when it's easy, you don't care about it. And so strategies, and these are about institutions. I'm doing a workshop tomorrow with a subset of y'all, and we'll talk about individual strategies there. But translation is a strategy. If the way you're doing the work is banned, translate it to something else, but keep the mission the same. People have been doing that for a long time. Collaboration. Y'all can collaborate across 11 institutions to collaborate to maintain DEI without us having to go back. And then resistance, which you're already doing. And so with that, I want to end my talk thanking the women who have helped make me the scholar that I am. I think we have a few minutes for, hold on, let me keep this on. I think we have a few minutes for questions. Sure. If not, I can tell y'all a little bit about some of them.
Well, if no one else has questions, that means you did a really good job.
Thank you.
I'll use the mic because I'm an expert in C200. One, this was an incredible talk. Like, hit a lot of things in a really cohesive way that I really appreciated. I thought something that was like, something that really stood out to me was we haven't been able to make a physicianship, and I would argue also like a scientistship, but perhaps to a lesser extent, because there's sometimes more flexibility in science than in medicine, that like matches the people that we treat.
Mm-hmm. I'm having a difficult time hearing you, sorry.
I'm curious, like, what you think we, like, medical schools especially need to do to help make, like, who is the onus on to make a physicianship that matches the people that we treat? And probably it's on a lot of different levels. And what are the actions that people need to take at some different levels? That was kind of broad, but you get me.
Yeah, and I mean, I think about this question a lot, and I think, so more senior people listening online will look at me as could look at me as a physician in training who's speaking prematurely, having not actually finished becoming a physician. But I have been a patient with a chronic illness for almost 20 years. And I think the root of it is where medicine lost its way when it became about prestige over service. Because I think the way that we decide who gains access to the rarefied halls of being trained as a physician is about who deserves to be here based on artificial meritocratic BS, as opposed to who can serve the best. I think about things like step scores and that we know, well, first of all, the STEPS tests were designed to be minimum threshold competencies, and now we use them to discriminate between people to move forward. And we know those don't relate to who's a better physician. We know that those other aspects of bedside manner, even clinical reasoning, anyway, I'm going on this side. We know those things aren't the things that matter for treating people. We also have studies that show that Black and Latinx physicians are more likely to treat underserved people. All of this is to say that I don't think medicine has reckoned with its professed and actual values enough to really change that. I think that if we wanted to correct the physician shortage, if we wanted to correct the difference between who we treat and who we are, then it's relatively easy to recognize we need to reshape how we select people and how we train them.
Incredibly well said. And now I have another question, which is like, oh, sorry, did you have a question?
I think you should do it first, but then I think we'll follow up. I think that really hit a chord with me. I think a word that gets tossed around a lot is like professionalism and the use of that word and kind of the weaponization of that word. I was just wondering if you had thoughts on how that is used in training and, I don't know, ways to push back when that strategy is used. Without being a professional. Right.
Yeah, I actually wrote a paper with, this is more conceptual, with this person here. It's called Resculpting Professionalism, and it's in Annals of Family Medicine. And I think that professionalism should be the attributes that allow you to do your profession the best. My patients, when I come in with loud makeup and tatted, I have the best connection with my patients, the absolute best. And we use the metaphor of unfinished sculptures in that conceptual sort of viewpoint, because and we took a historical thinking around it, but and this is something that you can dismiss, but I really think the way professionalism is weaponized is to make people approximate being white men as much as possible. They define professionalism. I mean, we saw that in the article that came out of surgeons rating people's online profiles, and it ended up them just like screening women in bikinis and like saying they were unprofessional. I think that, I'm trying to say this delicately, which is why I'm stumbling, but if we try to, like, I will never be that, and many of you will never look like that, and so we end up just moving around like carved out versions of ourselves, trying to approximate something that we can never be. And if you ground professionalism in how do you become the best physician, I think it actually becomes a lot more broad. Like the ways that I connect with my patients, I end up looking like them more, I end up talking like them more, I code switch less, all the things that are taught that we are either implicitly or explicitly aren't professional kind of get brought into the door.
Okay, my question, my next question is like kind of more like PhD focused, which is like, I think a lot can feel very removed from science, from like the mouse house, and like you mentioned it earlier, and I'm wondering if you could like circle back to how you see some of these themes. Not me saying circle back to how some of these themes show up in like science specifically, is like biomedical science specific. Like, I mean, physics is important, but like that's out of the scope of this space. Yeah.
Yeah, so I will say, and I'm about to whack a bunch of people with this one, science is never so sloppy as when they're looking at sex differences. How many MRI studies have you seen people lighten up the brains of people who are male and female without defining how they measured that? They didn't say, was it gonadal sex? Was it hormonal profile? Was it any of those things? And we take so many things because there's so much rigor around other elements of science until it gets to social categories, which we take as fact, and we simplify them, because if we were forced to really interrogate them, we would find that they're not so simple. Sex, even if you think of it as just biology, is really complicated. It integrates, to get from genetics to what we see, you have your genetic level, you have epigenetics, you have hormones, you have all of these different processes have to be integrated. And so for you to just simplify it, basically looking at external genitalia, is actually just sloppy science. And there are smarter neurobiologists who are MD PhDs who do basic science day to day. If we talk about machine learning, I got you, but I can show you some of their work.
Could you maybe speak to us about how I think that we all know there's a leaky pipeline in academia and medicine, especially for people with multiple marginalized identities. Can you speak to us about how mentors and people who are already faculty and in these positions, regardless of their identity, can help us break this leaky pipeline?
I want to preface this by saying that I'm still in most ways, very junior, but I also am actively mentor. I have PhD students who I'm on the dissertation committee, and I'm the methodologist. I work with them. I have people who I'm their thesis advisor for the MPH, and that kind of thing. And so I can speak. I'm just giving you that lens so you understand. What I've learned is that I had to assemble a team of mentors, and because I'm the only openly Black trans woman at Penn, so I'm not gonna get mentored by a Black trans woman. So I can't use that as my metric. I identify what I want mentorship around from people and what specific thing. I have career mentors, I have research mentors, I have people who are just mentors for writing. Like, I don't really like their science or their science is what I do, but they know how to turn a phrase and they know how to make the page sing. And that's what I come to them about. Well, I'm not gonna point them out because I just said I like their science. And I like some of it. But when it comes to mentors, in my role as a mentor, because of who I am, I always get Black and trans mentees just because they come to me, and that's kind of because they want an identity match. And I find that as a mentor, I end up having to do a lot of repair from the harms that have been visited upon them by their experiences in academia up until that point. And so this actually integrates her. She was the first person who I ever worked with who just assumed I was brilliant at baseline, didn't have to ask questions. I walked into her office the first day. She was like, I'm a tenured professor, I do what I want. What I want is to mentor Black and Latino people. Most of the time, they don't expect you to write papers. With me, you will write papers, you will be published, you will be successful. And then she dismissed me. And then she gave me all the tools I needed to get there. And that's what, and I have a version of that with my mentees. And I tell them that you can bring all of the failures and things to me. Your goal isn't to impress me. Your goal is for me to work with you to impress everyone else. And so having mentors who had that kind of grace for me was very helpful, with boundaries, with standards. But yeah. I think we have time for one more question. Maybe not, depending on how long-winded I am. Did you have a question? They keep looking at you like you had a question. Yeah.
I had one that was half brewing, but related on that last point, like how do you reconcile the value that identity matching and mentorship gives with the disproportionate workload allocation that requires, and how that the cost of that in general?
Yeah, so what I say, to achieve it, minority tax is inevitable if we're trying to get to equity. And so lament it all you want, but you can't get there without it. Compensate it is what you need to do, and I demand compensation. And I also am selective. Again, this is data, this is studied, that people who, like white males, get mentorship more easily because they have more identity matches across multiple disciplines. And so it is, I think, a moral imperative to correct that. And so I am more giving of my time to people of color and trans people than I am to other people. I'm not exclusionary, but I am more likely to create space in the 25th hour of the day for somebody who I know will be less likely to have an identity match-based mentor. And so I encourage other people to distribute that labor and also recognize that you can mentor somebody who is right next to you. Peer mentorship, she and I are both MD PhDs. We dragged each other tooth and nail through our MD PhD programs, okay? She taught me epi, okay? We taught each other, like that was what we did. So yeah, peer mentorship is powerful. And peer mentorship, junior people too, like work together as a group. We have many shared mentees. I think that's 6:30, so.
Okay, y'all are welcome to hang around, approach Elle, approach the bench, etc. Go home, take good care. Love y'all. See some of you tomorrow. If you want to come tomorrow and don't know about it, please approach the bench and we'll get you connected. All right. Yay. Many blessings, much love.
Oh, just consider, I feel like I'm going to consider that last part a call to action too, to take care of each other and your community and look out for each other, guys. Thank you so much for coming.
Thank you all.
You gotta comment. I think Dr. Lett, amazing presentation.